Can you start the countdown? Hello, friends. Welcome you once again to the brand new episode of GICS Rapid Journal Review, where we discuss some of the recent journals and try to dissect and extract the best possible informations from them. Tonight, we are again going to discuss on a recently published study. This is not a randomized control trial. It is an international observational study, and it is unique in a way because it has combined one retrospective cohort with an international cohort and combined them to give something which the authors claim is akin to a meta-analysis. We will discuss further to that during the course of our discussion. So tonight, we are joined by our presenter is Dr. Ashwin, who is a DRNB trainee at Max Shalimar Bagh in New Delhi, who will be moderated by Dr. Saurav Das, Senior Consultant of Critical Care Medicine at Max Shalimar Bagh. Welcome you, Saurav and Ashwin. And we are also joined by Dr. Ajay Kumar, who is a professor of gastroenterology, medical gastroenterology at GV Pant Hospital. Welcome you, Ajay. We are also joined by our guest, Dr. Karthik Rao from Bangalore, from Manipal. Welcome, Karthik, after a long time.
Yes,
and as usual, we have our regular panelists, Pradeep Rangappa, Dr. Ajit Eke, and Kapil Dev Soni to carry the discussions further. Now, without wasting any further time, I would now request today's presenter, Ashwin, to share his slides and present today's study, the effect of early full anticoagulation on acute mesenteric ischemia and international cohort study published in the intensive care medicine. Can you please share your slides and start?
He's got disconnected.
Yes, please.
He has got disconnected, sir.
Okay, I'll just some problem I think so is.
Saurav, can you start presentation so that he will take in from where when he joins, he will continue further.
Yeah, just give me. I'll make it all, then I'll start.
So this is one study which had a different design altogether because it had done a retrospective cohort, and then it is the descriptive analysis of a prospective cohort, which is called the mosaic cohort, and is integrated with the AMESI trial. AMESI, this is also an observational study which was published in 23. So therefore, it contains large, robust data. And the primary reason of doing this study, because the reported occurrence of AMI or acute mesenteric ischemia is so low that large studies or a single study could not rely on adequate recruitability. So the patients were less in number. And so over a period of time, we got too few studies to infer upon on the results of the treatment to this condition. So the authors had, in the AMESI trial, they had given a full anticoagulation, and it was published, and it had a remarkable effect because it included almost 17 ICUs. Now, this study has also included, I think, 20 ICUs or 37 ICUs, I forgot, but it had a very good, but the most important part is that it included both expert centers and non-expert centers. In expert centers, the results are expected to be good because the overall expertise of the system in treating such patients is good. But this study also included the non-expert centers to improve its generalizability. And as we know that a lot of times the observational studies, the quality of observational studies are determined by their generalizability. And that's why we rely upon. So this study had a very good generalizability because it included the expert as well as the non-expert centers, one center from the mosaic and the remaining centers from the non-mosaic. So that therefore this, yeah, Ashwin, are you ready with your presentation? Can you share your?
Yes, sir.
So you,
I'll just do it in
yeah,
a while.
yeah. So you can start your presentation now. So this was all about the study. There were certain loopholes. Of course, we will all discuss as during our course of discussion as we dissect the finer things, the nitty-gritties of the study. But definitely this is something which is adding value and information to our existing knowledge of this condition, which is so diverse and which can have so variety of presentations. Yes, Ashwin, you can start.
There's some technical glitch happening again, sir, because I'm being popped a message that I'm getting disconnected from the meeting once again.
Okay, if
Then
you
then
get
it's
disconnected,
then
then Saurav will
We
continue.
can hear you. We can hear you.
then I'll start presenting. Okay.
Sir, just please
Sir,
give me 2
I'll
minutes,
start
sir.
presenting. Yeah. Okay.
I'll just try to see what is the issue, sir. I'll just do it.
What is the message you're getting, sir?
Yeah. He is getting some pop-up messages that he is getting disconnected.
No,
Saurav,
what is the message exactly? What is the message?
Really sorry for the technical glitch, sir, but I don't know why it is happening.
but now is it okay? Because we can
I can see
right?
my screen, sir, but it is a very small window in which I can see it, so
Then
it's
it's okay.
not readable to me.
Oshin, no problem. I'll
You
present.
stop sharing
Okay.
and let Saurav present.
Okay. Oshin, stop there.
Yes. So again, same message.
Yeah.
So can I give it one more try, sir?
You want to try? Okay, try.
No, please start. You will let it go roll over and then we will see.
Sir, Dr. Saurabh will share the screen. You can maybe present it. You can, if you can
Yeah.
see it.
Or you can present like this.
Yeah. Good.
Okay, then you present. Oshin, you present. Yeah.
Thanks.
I'll just change the slides.
Thanks. So a very good evening to all the respected panelists present here. This, what we can see on the screen right now, is the AMESI study. It was a study on the incidence, diagnosis, management, and outcome of acute mesenteric ischemia. It was a prospective multi-center observational study which was published in the Journal of Critical Care in the 2024 edition. But what we are going to discuss here right now is not the AMESI study, but a study which has included the components of AMESI study along with another study. So acute mesenteric ischemia occurred in about 0.038% of could you just go back, sir? Of the adult admissions in participating acute care hospitals worldwide. Occlusive arterial acute mesenteric ischemia was diagnosed in about 231, that is 55.3%. Venous in 73, which was 17.5%, and non-occlusive mesenteric ischemia in about 55 patients, which was 13.2%. Overall, in hospital and 90-day mortality of acute mesenteric ischemia was 49% and 53.3% respectively, and among subtypes was lowest for venous AMI, which was 13.7 and 16.4%, and highest for non-occlusive mesenteric ischemia, which was 72.7 and 74.5% respectively. So the study which we are going to discuss here is a study. It is a study on the anticoagulation management and outcomes in critically ill patients with acute mesenteric ischemia. The principal investigator was Heinz Lagbar from the Regional University Hospital of Montclair, and it was published in the Intensive Care Medicine with an impact factor of 21 in the June 2025 edition. The funding of the study was done by the Estonian Research Council, grant PRG 1255. Now, speaking about the conflicts of interest in this study, there were not many conflicts of interest in the study, and the ones which were there were bleak enough to not affect the outcomes of the study to that extent. Next slide. So speaking of acute mesenteric ischemia is actually caused by interruption of blood supply to the intestines, leading to cellular damage, intestinal necrosis, and commonly patient death if it remains untreated for a long time. The types of mesenteric ischemias include non-occlusive, mesenteric artery embolism, mesenteric artery thrombosis, and mesenteric venous thrombosis. The overall incidence is low. As we can see, it is between 0.09 to 0.2% of all acute admissions to the emergency departments, but the mortality far exceeds 50%. So it is quite catastrophic. Previously speaking, as we've had the whatever studies we've had are basically done by the surgical societies in different parts of the world, but there is no study which has focused on the recommendation of early anticoagulation per se. There is no evidence on early use of anticoagulation. No randomized control trials have been by far conducted due to low incidence, and we are yet to explore the early use of anticoagulation and the relation to mortality. So this was a combination per se of both prospective cohort, which was the MOSAIC study, the Montpellier study on acute mesenteric ischemia and critical care, as well as the retrospective AMESI study cohort, which I've already discussed previously. The diagnosis of acute mesenteric ischemia was actually based on or through one or more diagnostic modalities, including the CT scan, mesenteric angiography, endoscopy, surgical exploration, histological examination, or autopsy findings. The acute mesenteric ischemia was classified according to the following criteria. It was either arterial occlusive in case of arterial embolism or arterial thrombosis, venous for de novo venous occlusion, and non-occlusive or NOMI as we call it in case of non-occlusive mechanism and various miscellaneous causes. So the interventions were divided into two parts. It was either early intervention or late intervention. Early intervention meant therapeutic dose of anticoagulation was given within 48 hours of diagnosis of acute mesenteric ischemia. And late was that only prophylactic dose or therapeutic dose was started after 48 hours of diagnosis. And the therapeutic or full dose of the anticoagulant use was actually defined in the MOSAIC cohort, but it was not defined in the AMESI cohort. And the treatment protocol included revascularization procedures, which included either surgical interventions like endarterectomy or bypass, or interventional radiological procedures like angioplasty, stenting, which were performed alone or in combination, including hybrid approaches. Bowel resection referred to any surgical removal of intestinal segments judged to be necrotic or non-viable during laparotomy. There were no standardized treatment protocols that were applied across centers, and the patient management decisions, including anticoagulation strategy or surgical interventions, etc., were made by the attending physicians, which were completely based on the local practices and clinical judgment. So speaking about the outcomes of the study, the primary outcome was to primarily study the mortality at day 30 or the 30-day survival. And the secondary outcomes included a barrage of things that we were about to see, which were duration of mechanical ventilation, ICU length of stay, occurrence of hemorrhagic complications, including digestive hemorrhage or any non-digestive hemorrhagic events and blood transfusions, and the survival at day 90 or 90-day survival. Now, data collection included the demographic details at the time of admission, like age, sex, and any comorbidities, which were calculated using the Charlson score. The reason for ICU admission, whether it was medical, whether it was an elective surgery that meant to be performed, whether it was an urgent surgery or trauma. Presumed etiology of AMI, whether it was arterial, venous, or non-occlusive, and severity scores upon ICU admission, like sepsis-related organ failure assessment SOFA score, and simplified acute physiology score 2 or SAPS-2 score. Regarding the patient management, data referring to the medical treatment administered and whether surgery was conducted. And if the surgery was conducted, whether it was a bowel resection surgery or a vascular correction, which was done either through surgical or endovascular procedures, all of that data was recorded. The occurrence of hemorrhagic complications was also recorded. Data regarding anticoagulation therapy and antiaggregant therapy was also taken. Time to deaths, to first and second surgeries if needed, and to any hemorrhagic complications was also recorded. The point to be noted here is that data on hemorrhagic complications was only available in the MOSAIC cohort and not in the AMESI cohort. Now, what all statistical tools did they use in this study? It was Student's t-test and Mann-Whitney U-test, Fisher's exact test. Effect size was calculated using the Cohen-D, Glass Delta, and Kramer's V-test. Univariate Cox model to determine whether early full-dose anticoagulant therapy was independently associated with a 30-day survival. And hierarchical multivariate Cox models also to determine the same, but after adjustments of several variables. The performance of the Cox models was assessed using concordance index, also called as the C index, time-dependent receiver operating characteristics or ROC, area under the curve at day 30, sensitivity and specificity. The proportional hazard assumption was examined using the Schoenfeld residuals. To consider the possible differences between the cohorts, they used a mixed effect Cox proportional hazard model with cohort as a random effect. A negative binomial regression to search for an association between early full dose anticoagulation therapy and mechanical ventilation duration, and between early full dose anticoagulation therapy and ICU length of stay was used. After that, the Fisher's exact test was performed to determine whether early full dose anticoagulant therapy was independently associated with adverse hemorrhagic or transfusion events. And finally, a univariate Cox model was used to determine whether early full dose anticoagulation therapy was independently associated with 90-day survival or not. All these tests were two-sided with a p-value of less than 0.05 defining statistical significance. Now, this chart basically shows the number of patients that were included from both of these trials. From the Montpellier University trial, there were a total of 147 patients, and from the AMESI study trial, there were 223 patients. So in all, a joint cohort of 370 patients were there. The primary analysis was association of anticoagulation with 30-day mortality, and all of these patients were enrolled in the study. Now, speaking about the outcomes, ideally there should not have been much variations between the early and the late interventions, but actually there were seen to be a few variations. Like, for example, the patients with pre-existing atrial fibrillation, as we can see here, they were seen to be more in patients who were intervened early, in cases of early intervention. Likewise, venous thrombosis, as we can see, the venous thrombosis was also significant more in the patients who were intervened early as compared to the patients who were intervened late. Also, SOFA score at the time of diagnosis, SOFA score was seen to be higher in cases of patients who were intervened late as compared to those who were intervened early. Also, renal replacement therapy. Renal replacement therapy was also seen to be higher in patients who were intervened late as compared to those intervened early. So these were the factors that were actually varying between the two groups of early intervention as well as the late intervention. So the primary outcome was that 30-day survival was around 53.5% in patients who received early full dose anticoagulant therapy and about 41.7% in patients who did not. So the p-value was 0.01. Secondary outcome was a longer duration of mechanical ventilation. It was found in patients receiving early full dose anticoagulation. ICU length of stay, not much difference was there with 12.8 days versus 10.3 days. Early full dose anticoagulant therapy was associated with a better 90-day survival with a p-value of 0.02. In the non-occlusive mesenteric ischemia subgroup, early full dose anticoagulation was not associated with a better 30-day survival. In patients with arterial AMI, early full dose anticoagulation was again seen to be associated with improved survival. In venous acute mesenteric ischemia, the sample size was in the non-early group was not sufficient enough for a subgroup analysis. So now speaking about the strengths and the weaknesses of the study, the chief strength of the study was that this study was meant to address a very clinically important topic, especially in the one in which the evidence is very sparse. The authors claim that by integrating these two cohorts, the analysis achieves a level of evidence which was similar to that of a meta-analysis. And there was a lot of heterogeneity in terms of demography, disease severity, and treatment protocol, and the authors claim that it improves the external validity of the study. However, there were also a few weaknesses, the most important being about the study methodology. This study was a non-randomized, non-blinded mix of both prospective and retrospective study. And there was a lack of uniformity regarding the dose or the type of anticoagulation that was used. And the early and the late anticoagulant groups were not comparable even in terms of disease severity. So overall, we can see that although this was a pilot study, it had its share of strengths and also its share of weaknesses. But all in all, we can say that this was a novel study. This was a pioneer study in the use of anticoagulants in acute mesenteric ischemia, and we can further go about using the anticoagulation to achieve a better survival as the study has shown.
Okay, thank you, Ashwin. You presented it nicely, quite wit. And now I move on to Dr. Saurav, who was his mentor, to elaborate on the biostatistics part of this study. Yes, Saurav.
Actually, before commenting on the study itself, there are lots of statistical tools were used, and there will be many DNB students or student juniors. And for sake of them, I want to just not elaborate, just want to say the meaning of those, what they mean by those terms. One is effect size. What is effect size? Effect size, and we use p value and effect size. P value means that they say whether the difference exists or not, and effect size will say how much is the difference. When we present some data, some our result, actually we should mention both p value and effect size. So effect size can be calculated or can be presented in different way, like as already mentioned in the study that it was Cohen D test was used. Also, you can use odd ratio or relative price ratio. This can be used to show your effect size. Now coming to, they use Cox regression model on peer and proportional hazard ratio. This is survival time analysis. They depict how many patients survive after a certain period of time. This also we call Kaplan-Meier curve. In this graph, we can see here the blue, the Kaplan-Meier curve of the patient who were given anticoagulant early, and the red where anticoagulant given after 48 hours, and after 30th day, the number of patients who survive was more in patients where anticoagulant is given early. And if you want to uh, compare these two curves, we use log rank test. And you can see from the demographic and that there are lots of variables that might affect the outcome of the study. Because they have so far are not comparable. So far score was high in the late group, atrial fibrillation was high, RRT was high. There are lots of age was higher in one group. So there are lots of variables that might affect the outcome of the disease. So to see the outcome of this, they did Koch regression test. If you want to see the only one factor, you will do univariate Cox regression test. And if you want to do multiple factor, you do it multiple Cox regression test. Just want to say the meaning. Now also there is one term like this is called least lasso method. This is called what is this lasso regression? Regression, we know that there is relation between something, two things, like the price of a house is depend upon the size of the house. So there is a linear regression between the size of the house and the price of the house. But there are many other factors, like maybe the location, maybe where this house is has a lift or not, whether this house has a parking or not. But we cannot consider all the factors. To simplify the regression model, we take most one or two most important factors, and this is called lasso regression, where we ignore the useless factors. For example, we can ignore the color of the house, or like whether the house has a lift or not, and we can just consider the size of the house or the location of the house to consider the price. This is called lasso regression. Again, uh, this co-confidence index or C index, it will tell the accuracy of a model uh, to predict perfectly or not. Like if C index is 1, it's perfectly, the model is perfectly fine. If zero point 0.5, it's not better than random guessing, and if it is 0, it is always wrong. Another is, we all know about the receiver operating characteristic curve. What is time dependent receiver operating characteristic curve? Uh, the accuracy of a model can change over time. Ideally, it should not change, but it may change. For example, creatinine level 1.2 will help you to differentiate between the patient with kidney dysfunction and with normal kidney when the age is around, suppose, around 30 to 50. But when the patient will grow old, even his creatinine 1 may be abnormal because his skeletal muscle is low, so heparin creatinine level is low. So that ROC of the ROC of creatinine 1.2 will change over time. Ideally it's not change, but it changes over time. So it is called time dependent receiver operating characteristic curve. And uh, just a minute. and this one's cornfield residual, they detect again, they detect the violation, because as I already mentioned, this association should not change over time, and if this residual detect the violation of assumption that whether it changes over time or not. Again, these are other things like Cox model. Cox model can be fixed model and random model. When there is multiple things, like for example, chemotherapy and the survivability, we're looking at this. But uh, just a minute. Suppose we are looking at the effect of chemotherapy and mortality. But if the patient is in a good hospital, the overall care also may affect the patient outcome, not only the chemotherapy. So when we use this mixed effect of co-model, we take consider all other effects apart from the main outcome. Now, you can, in the study, they said that duration of mechanical ventilation was more in patient with who got
Early.
early anticoagulant, and they said that they, in the discussion they wrote, it is due to the immortal time bias. Now, I just want to explain what is immortal time bias. Suppose I want to explain this by this example. Suppose we want to see the effect of exercise on cardiac health. Okay, but to be effective, at least it should be patient should, or someone should do exercise for 6 months. Then only you can say whether it's affecting cardiac health or not. But if someone died before 6 months, then we don't consider that patient was doing exercise. So unnecessarily, we increase the mortality when patient is not doing exercise. Actually, patient was doing exercise, but since he didn't complete the entire 6 months, we remove it from the intervention group and we put it in the non-intervention group. So it is called immortal time bias. It favor the patient, favor the group, non-intervention group. Okay. So coming to
Thank you,
the study,
Saurabh. Yeah. Thank
yeah,
you,
yeah, yeah.
Saurabh. You have nicely explained some of the important facts which are related to the study, and that makes understanding of the study easier. But before we go into the deep study, the first most significant question that the study throws or puts forward before all of us is the understanding that are we really scared in using anticoagulation? And for that, I am going to today's subject expert, Dr. Ajay. Can you hear me? That is there any rationale in being scared to use anticoagulation in patients with acute platelet-centric ischemia, or is such a fear unfounded? Ajay.
Thank you, sir. Good evening. Actually, we do see this patient, but majority of our patients are of acute venous type of mesenteric ischemia. And in this patient, we do anticoagulate as a first step. And normally, we see prefer to heparin or low molecular Clexane in this patient. And we start with therapeutic dose. And we monitor them clinically. And in some patients, we also do nowadays US guided injection portal vein or SM, mainly the portal vein thrombosis, acute when there's acute thrombus and the patient ongoing pain. Normally, arterial ischemia we don't see so much. They may are manual cardiologist, but the venous case do get admitted with us and we manage them medically. And we start with anticoagulation and antibiotics also in this for the patients. So anticoagulation does help. And a lot of time we are apprehensive the patient will bleed, but that doesn't happen in real world setting. It's actually one of the important therapy which has to be started as early as possible.
Fine, fine, Ajay. So as you told that you mainly deal with the venous ones where you try to anticoagulate early. Now, Kapil, this study includes a mixed bag of arterial, venous, and NOMI all together. And the authors themselves admit that in the NOMI, there was no benefit in the subgroup analysis, and their numbers are also variable that you cannot figure out much from them. Now, while doing a study, it is essential to stick to one group or do some propensity matching so that the individual effects of whether arterial thrombosis or venous thrombosis or non-occlusive mesenteric ischemia can be found out?
Yeah, particularly in this study, because the event is not that common, and that's why the authors had to combine two big data sets which had actually captured the events. Primarily, if you see, even one of the data set was a prospective data set, there was already a retrospective data set. But essentially, this is a retrospective study. And when you have a retrospective study, you will have a lot of other biases creeping in. The problems of retrospective study will be creeping in. Doing a specific population only for a Venus, they have mentioned subgroup analysis, but obviously they didn't have a power to say whether the
Yeah,
effect is there
because it
or
was
not.
not propensity matched. If they would have
No,
only
so the propensity is different. So when we say a propensity matching, it means that we are trying to distribute the probabilities in equal balance in different groups, right? Unfortunately, this trial, because retrospectively, and they have not employed methods to uh, distribute the probabilities equally in different groups.
correct.
Therefore, the causation you cannot make out. What you find is an
Exactly.
association, and that association does not mean causation. Means we all know that.
Absolutely. This association, and another important aspect of the study when it makes out, I will come to Saurav also, I will come to Ajay also, and Pradeep also. If you see that this is one study which shows 12% benefit, say 53% versus 41%, 12% benefit with the early anticoagulation, and yet it shows a number needed to treat to be 8. That is to get result in one patient, you have to. Doesn't that seem to be contradictory? Kapil.
So, number needed to treat is actually 8, but the effect size is driven primarily because of venous thrombosis, if you look at. And one of the cohort which is contributing more is the AMESI cohort. Mosaic cohort, which had a sicker patient, they didn't have that much of a difference in the effect size. So this is a retrospective study. The effect sizes would be exaggerated. You will not find in a true event, in a true sense, the true effect size. These retrospective may end up in exaggerating a small differences in a large effect size. So this is a problem with retrospective. If you look at 90-day mortality, there's no difference, right? Even the 90-day mortality, they are a group which had early anticoagulation, they had a higher mortality. So this does not make sense. So I still see this is a hypothesis generating unless we have a prospectively database, prospectively studies or other way of looking at causal inference. Not much of association can
Yeah,
be made.
but
Whether
the
we should,
mosaic was prospective, but it was too small.
yeah, no, the mosaic,
Mosaic
still it's an observational study. It's not
Yes.
a randomized control trial. So
Yeah.
that's a problem.
That's probably difficult to do a randomized. Well, I go to Saurav with the same question, a bit putting in a different. How good was it for them to describe to leave that that full anticoagulation dose at the discretion of the physicians, because it was either early before 48 hours or prophylactic or late afterwards, but exactly the dose was. But they could have, in an observational studies also, we have seen earlier observational studies which had defined the dose so that there can be meaningfully exclude the forms which were actually early and actually which were not so, sort of.
Yeah, just I want to start with something else. Like, it is
No, you
not
first
that
proceed with this.
I'll just come to your question also.
Yeah, okay. Go
It
ahead.
is not that we didn't know that we should give anticoagulant. This study emphasizing that whether we should give it early or not. And what is the problem of giving it early? First, the diagnosis is late because we need to give contrast. So a patient may have hypotension, patient may have high creatinine, and usually the
Contrast is not
contrast is
given.
delayed, and that's why it is delayed. And one it was diagnosed that we have a mesenteric ischemia. Priority is for revascularization, and then there is a plan for surgery. Again the anticoagulant is delayed. These are two reasons why. But now again they showed that this is only not helpful in venous, not very non-occlusive, only arterial thrombosis. But again, it is easier said give early anticoagulant, but practically it may not be because when surgery is planned, you cannot give anticoagulant. So this. And coming to your question, those I'm not very much bothered about those. Those is almost like equivalent across the world. Claxan, Fragmin, Fundapoin, whatever anticoagulant you can give, but and dose is almost similar. Unless patient have kidney dysfunction, you can give per kg per kg
I
coagulation.
think so. Saurav, you have made a very important point. I will come to Ajit to it, but before that, I will ask Ajay. Ajay, you are there. Ajay, just like Saurav said, that even if you want to give full anticoagulant in the stage, but initially the same problems may happen that patient, it is not possible to give contrast, number one. Number two, revascular surgery is a priority. It's again, a surgeon would be scared of if a patient gets. So there are too many deterrents to early administration of anticoagulation. How far do you think it is true?
Actually, sir, when we look at this aspect, most of time we are getting venous thrombosis, and the basically what you have to look is that whether there is any evidence of gut infarction or not. So what we do as a protocol, we do a CT in our patients as less possible, and if there is no evident sign of gut infarction, we start anticoagulation, and we do take a surgical consultation. Actually, sir, surgeons are also very hesitant because they have to do a very long resection of the bowel, and a lot of these patients will land up in a short bowel syndromes. So surgeon also they just want to defer the surgery, and in fact, when we look at venous thrombosis, it's slightly better because in this group of the patients, you just have to buy time because over the next 4 or 5 days, they do develop collaterals and which do take care of the thrombus. Actually, thrombus will never resolve with the anticoagulation. It has got main role of preventing the progression of thrombosis to proximal and distal end. It just stabilizes the thrombus. It will not dissolve the clot per se. Okay, so that's what you have to understand. We are just giving anticoagulation just to stabilize the clot, so that no further progression occurs in this group of the patients, sir. So you have to balance it out, and we do use anticoagulation, but that too with a surgical consultation, and we do keep surgeons in the loop, and they do see the patient with morning and evening with us for the rounds. And if needed, they do take surgery for the patient, sir.
One of the most worrisome situations that we come across is in sepsis, and sepsis, it is always non-occlusive MI, the NOMI, as you go hand in hand. Now, what are the patterns do you see where you find that anticoagulation can be beneficial? All those studies find that anticoagulation is usually doesn't give any benefit for NOMI.
Yeah, so when it's an arterial ischemia, when you have an arterial ischemia, maybe the anticoagulation is going to be more useful. Probably the NOMI may not be that much useful.
That is not useful.
Yeah,
Karthik, are you there, Karthik? Yeah,
yes.
You can continue.
Another major thing in this study, see, the thing is that you are trying to compare early anticoagulation versus late anticoagulation. You are talking about an early revascularization by late revascularization. With the basic thing, if at all you are comparing, mean the initial severity or whatever there should be some documentation, some kind of a uniformity has to be there. Like the severity of the disease or things should have been same. For example, see, the late anticoagulation means the anticoagulation has been given after 48 hours, and the early mean is there within 48 hours. So the thing is that some patients who had a significant coagulopathy or something right from the beginning, the
Absolutely,
surgeon,
the sicker patients are not going to receive. That is why you have seen it that
that's the thing.
patients
So
who had a
you
high
just cannot
lactate,
compare like
who
that.
had a high Apache or SOFA, whichever severity score. Yes, Kapil, they did not get.
So you are absolutely correct. Means that trips in the selection bias. That's called selection bias because all the patients who were stable, they end up receiving early anticoagulation, whereas patients who were little bit sicker or unstable, they were not. They were given late or they were not given at all.
So that also explains the immortal time bias.
Yes. So mortal time bias is different. So, but there's a selection bias, which is essentially you are selecting a patient which has got a better prognosis and you are intervening in them.
And the surgery also, if the bowel is not that much, if the early stage, the bowel is, partly damaged, whatever it is, maybe the surgical outcome would have been better. So you never know. Initially, how the comparison, then you never know. What is the severity of the ischemia? There is no data at all, just an observation study.
Absolutely.
So we just
so
cannot make
another important aspect.
I just want to add to Dr. Ajit. So these are basically unmeasured confounders. The study did not have data about why these decisions were made to operate or they were not made to operate. So these were unmeasured confounders which were not there in the data set.
Absolutely. And probably one of the more unmeasured one is the absence of hemorrhagic complications in the AMESI, because we only relying on the small data from the mosaic, and we also didn't monitor the coagulation parameters, etc., to find out the link between the hemorrhagic complications and the kind of changes that were encountered and the reasons behind this change. But another important point is, Pradeep joined?
Yeah, Anirban, I'm there. I just joined late. Yeah, I'm there.
Acha, okay, fine. If you are
Yeah.
there, then I can pass on to the questions, or I will go to Saurav. That Saurav, in this study again, you have seen times and again when such a study is done that the proponents of coagulation, they go in a very serial based manner, that they give a small dose of heparin first and then probably omit for 1 or 2 days in practical, in real life situations, and then probably if the patient improves, goes on full dose. Now, do you think that in this patient, in this large study, since it was a large cohort, so a lot of data which actually were shown to get a full early anticoagulant were may not have
May
got
not be
so?
true also. Yeah, actually, this is no, there is no protocol. It's a new protocol how to give anticoagulant, and there it was left on the treating physician.
Yes.
The mosaic trial, in the mosaic group, it was the patient was collected in over 15 years of time. It was started in 2009 and till
24.
2024 they started. So their practice changes over time. And the other MSc also, that international group, they also done in a different institute, and different institute had different protocol. So this is the image of having a retrospective study. No
Absolutely.
protocol.
Yeah. Ajay, I want to
And,
ask you one question that in which,
Anirban, can I just make one point?
yeah,
Just needed expert input because I'm just traveling somewhere. So when you look, I think for me, this when I looked into this study, Anirban, the whole thing that intrigued me was the mismatch between the two groups, which is the nature of any retrospective or observational study. If you see, I don't know if I need some answers from the experts here. The venous ischemia and arterial ischemia was more in the intervention group, and lactates also were more. So you would obviously expect this. There was a huge sort of a difference between the control, and we saw a good sort of an outcome where therapeutic intervention was done in this particular group, which needed it. So just I needed to know, how do you take on the face that this study is something that we need to incorporate into our practice, Anirban? I think that's very intriguing to me. There's total mismatch of the whole group. With, as Kapil rightly pointed, there's a huge selection bias in this. Mhm.
actually, there is a lot of selection bias that is needless to say, but there is also the point that since it was left to the clinicians to finally determine the patients in whom they felt that early anticoagulant would be beneficial. So that personal bias of that could have also attributed to that. So I think that it is a combination of both the biases. But one important thing which they also point out, I want to ask Ajay about it. Ajay, they have spoken about the heparin resistance. Now, how often do you, when you use anticoagulant in such patients with AMI in venous, how often do you recognize a heparin resistance, and how you diagnose it?
Yeah, sir, actually, frankly speaking, we don't get that many patients in our setting. So I can't
Actually,
really
nobody
comment
gets
upon the
that much
specific.
of setting in AMI. That is why they have done this.
Yeah.
Uh,
So yeah, that
time.
we see very few patients. To frankly speaking, we see like uh, one case every 3 to 4 months. So what I can say that whatever data we have keeping with us, we have seen like last 3 years around total of 5 to 7 patients, but we have not encountered such a pan-resistant per se in any of our patients. But if we read the literature, we do get how to suspect and diagnose these patients. So, and sir, we are not using heparin at our center. We are using sir molecular weight heparin. Actually, with heparin, you need to monitor every like tighter dose by monitoring APDT test. So it's not available in our setting routine practice. So we give Lexin, and this is because we are getting venous thrombosis, not arterial thrombosis with us.
Okay, so that means that heparin resistance, which they have tried to identify, may not be a big problem in all data sets. Another important question I want to ask Kapil. Kapil, I will come to Ajit after that. That when we design such a study using two different sets of cohort, although we say that it will add up to increase the generalizability, increase the robustness, but at the same time will increase variability, increase biases. Also, how do you know that whether the advantages outweigh the disadvantages or something like that? Is it by trial or error,
So
or is there some way to?
No. So what happens is that when you combine two different data sets, first you have to see how similar is the data set, how similar is the population, how similar is the intervention, comparator, and outcomes. Definitely, there is going to be some sort of dissimilarity. That's what we call as heterogeneity. There would be some differences, but the still you want to have a numbers with you. If you have a very small data set, nothing much you can do. But if you have a too big data set, at least you have some story to tell. That okay, so we have some story. Whether that story is how reliable, that's another question. But at least some data is there. So it's always a challenge whether we should combine and whether we should not combine. If the data is too heterogeneous, then there's no point, no sense of combining different populations. But if data is pretty much similar, not much of a difference, then still you can go ahead and combine. There are ways to do that.
So that is also a very important finding. I think that we will have to match to see how the two populations, how the two cohorts match each other in terms of their similarities and dissimilarities. Now, one big thing, again, I go to Ajit with that. Ajit, when we see the type of anticoagulation that we do, since this study had been, the mosaic has from 2009 to 2024 over a span of 15 years. How has, in your clinical practice, the practice of anticoagulation changed over time? Has it become more aggressive, higher dose, or remained the same? How do you see the change?
No, I would like to say that it's almost it is remaining the same. I can't find it, but patient
So
who is having
do you see that the low molecular weight has gained much wider acceptance, and then it used to be so in the early years, say 2009, 10, 11, 12, like that over these years?
Yeah. So the patient who is having renal failure patients, obviously you preferably go for unfractionated heparin. So maybe renal failure patients and obviously low molecular, but preferably go for a unfractionated heparin we already mentioned. And sometimes you prefer a dalteparin in those patients who is having renal.
Yeah, no, that Ajay told me already that the monitoring becomes much easier with low molecular weight heparin. But
and if it is bleeding happening, also the unfractured heparin you can try to reverse to some extent as well. But here it may be quite challenging as well. There is already a thrombosis there, but again, some bleeding can be to some extent it can be
it can be
Yeah,
controlled.
yeah.
So in such patients, if as the authors have said that there is a variation in terms of the early effect of coagulation on the nature of thrombosis, whether it is arterial versus venous versus mixed versus NOMI. Now, do you think that this variation can be attributed for some reasons also to the type of heparin being used, whether it is unfractionated or low molecular weight or something? Because in the end, they have also suggested that the further studies based upon the dose attributed to the different types should be done. So do you think that the same heparin can cause different means of bleeding with in case of arterial versus venous versus NOMI, etc.?
Yeah, so basically the unfractionated heparin, obviously you can easily monitor, you can do an APTT, you see that your APTT within the therapeutic range, 45 to 75. So the low molecular heparin is difficult we are just giving, it's difficult to monitor, 10A levels and all is difficult to monitor, that's one thing.
So Ajay, I asked you the same question.
Difference.
Ajay, is the risk of bleeding more in arterial or venous or in NOMI with the use of heparin, or it remains the same across all categories of AMI? I think, yeah, you are there.
Actually, sir, as per
As per the
literature, if we read
literature, you may not have seen too many to comment upon, but
so actually, if we look at non-occlusive patient or much sicker patient, because in this there is already hypotension, and in this group of the patient, actually thrombus is not the main thing, but hypoperfusion is there. So in this group of the patient, they have a lot of comorbidities. So that's slightly higher risk of the bleed as compared to other group of the patient. In venous thrombosis, slightly bleeding risk is lower as compared to the other groups of the patients. That's what I can say, sir.
so in venous, do you think that the bleeding can be lesser even when we use full dose?
That's right. Yeah, basically whatever patients we have managed here with venous thrombosis, so we are not seeing bleeding as a complication then. The mainly the thing which we have seen is that non-response to therapy because of excessive thrombosis. and those patients landed surgery. Bleeding we didn't encounter in our patient in any of the patient in our center. And normally patients actually are in ICU mainly, and this patient are more sicker because of underlying comorbidities. So because of that, they may be at types of bleeding or renal failure, other problems which are there in this.
So when it comes to the sicker patients, I'm going to Pradeep. Pradeep, are you there? In the sicker patients, what occasions do you attribute some, if you have any bleeding following the use of anticoagulant, that bleeding to be dose dependent, or versus that bleeding to be some kind of idiosyncratic, etc.? Because
So
there are
Anirban,
reports that even the prophylactic dose of heparin can also cause a lot of bleeding.
yeah, see, bleeding is a complex sort of a subject. Your question is more pertinent to ischemic bowel, or is it in general critically unwell, very sick patients?
In ischemic bowel, or in similar ischemic, in ischemic bowel, in acute mesenteric ischemia, what is the
Yeah.
risk of bleeding because of dose versus just because of the use of heparin itself?
See, here we are talking about therapeutic anticoagulation. Prophylactic, I wouldn't think there is a risk. But if you are thinking of therapeutic anticoagulation, I believe there has to be
So
some
prophylactic, you
consensus.
think there is no risk of bleeding? Ajit, do you think prophylactic heparin can
For
also
any
cause
sick patient,
quite a bit
of
of
course,
bleeding?
when platelets prophylactic, we do use it for all critically unwell patients, even with bowel ischemia. But if it is therapeutic, I would like to weigh the risk-benefit balance, and of course need consensus with surgical team if they are intervening. And I think that's what they have suggested in this paper also. How
Yeah,
surgery, the
there are a lot
surgery
of.
determined. The fact that patients would go for surgery obviously
Yeah. They have those criteria, has bleed, all those acronyms are there, one looks for. So the risk of bleeding in surgery increases much more than in the patients who are not undergoing surgery, only medical reasons. But my question was, Ajit, do you agree with this, with that theory, that the risk of bleeding is lesser with prophylactic dose, or do you think that there can also be bleeding with prophylactic dose of
So
heparin?
basically, prophylactic dose, you are using a lower dose. So unless there's an underlying coagulopathy or any underlying undetected, covert bleeding or something is there, I mean, there is a risk of bleeding likely to be more. But otherwise, since the dose is less, mean it's unlikely for the dose cup dose, mean obviously it's unlikely to bleed more. But unless there is an underlying coagulopathy, there is a covert, bleeding is happening.
Yeah, so it can be a covert bleeding or an overt bleeding. So covert bleeding will get missed. So that is also a probability, and that should not be ruled out just because we are using a prophylactic dose. That can too happen. Saurav, I forgot to ask you the same question which I had asked Kapil in the beginning. That why do you think in this study NNT was so high, 8, although there were so much of indicators to see that this was early full anticoagulation is useful, and
I think Dr. Kapil already explained actually why NNT is high and why effect size is so high. Because we even don't know what is the power of the study. And hello, can you
that
hear
we
me?
even may not come to know in any observational study.
Yeah. Yeah. So that's why
But this is
the
a robust
NNT
study.
here is not, yeah, not, sorry.
Yeah, go
I
ahead.
think my net is not good. No,
Yeah,
I
please
can't
go
hear.
ahead. Please go ahead. I think we are.
So just to intervene here, so what NNT exactly is 8 patients. So what does that mean? That means you have to treat 8 additional patients to get one more better outcome. That's it. That's an NNT. And I think it's a reasonable, it's not a very high NNT, it's not a very low NNT, but it's a reasonable 8 patients if you treat extra, you will get one more benefit compared to a late or a delayed anticoagulation. That's all what it says NNT.
That is also says it. So when we see these two studies from the two arms, or because they had a mutual data sharing agreement, so MSc. So if you find the MSc the cohort, do you find, and when you match it with those of the mosaic cohort across the studies, we find that most of the complications of the MSc cohort were of higher magnitude in comparison to the mosaic. So does that mean the mosaic, despite because of its retrospective nature, might have missed a lot of complications, and just for the simple reason that the investigators were not prepared at all, or they never thought in that.
So
That
in
they
fact,
were-
it's other way. It's in fact it's other way around. When you do a prospective study, you are more means you are more likely to get or capture complications compared to a retrospective database. So if you have a prospective, you know what is, you define a complication, you are more likely to catch it, and that's a true number.
Yes, Saurav, any comments on that?
It's actually my I got a disconnection connection problem. I
No,
can't hear it properly.
the question was, when
Can
if you
you?
see the if you see batch, if you find lot of mismatch between the AMESI cohort and the mosaic cohort, despite the, do you attribute
Correct.
the retrospective nature of the study for the mosaic, or do you think that it was because
Correct.
the investigators were ill prepared or less prepared because of the time duration to observe such effects?
No, I actually I don't want to blame the investigator, because the nature of the disease is such that very low incidence, 0.2 to 0.3%, and with very high mortality. So it's not possible to design a prospective randomized control trial where you give half of patient anticoagulant and half you don't give anticoagulant. So this is the best. Can you hear me? So I think this
Yeah,
is
yeah.
the best. They did the best what they could do.
Okay.
Earlier we didn't have any evidence. Now we have some evidence regarding the early use of anticoagulant.
Absolutely. So this is one of the such studies which has tried to touch upon an area on which we don't get too many large studies. Although observational, it has come out with some definite observations, and particularly the observations can be, if it can be extracted meaningfully, like if the sicker patients, we can see that they can have more of complications following the use of full dose anticoagulation, and also then yes, Kapil, you want
So
add anything?
just to add, I think one of the intervention which is not yet we have discussed is basically the surgical intervention,
They
and
have
one of
discussed.
the fact
They have
yeah,
discussed. These were the only two
yeah.
factors.
So that's the most one of the most critical intervention that can actually have bearing on the outcomes or the survivability of the patient. So if it's done early, then the chances are better. If it's done late, then the probability goes down.
So that's what they have mentioned, that early full anticoagulation and revascularization oblique surgery are the only two factors which they have found by using this multivariable progression to be dependent. So that is explains that this study, although it may have a lot of limitations because of its nature of combining a retrospective cohort with a prospective one, yet it gives us some informations, some meaningful informations can be extracted, and larger trials can be planned in a definite way by designs, by taking the necessary inputs from this study to give elaborate informations. Now, since we have already exceeded our time, I will ask the same question to all the panelists as I always do. I will start with Saurav. Saurav, if you have to take two messages from this study, what are they?
The only thing that I like, first, whether this study will change my practice or not. With the should I? Yes, I will try to incorporate the finding of the study by giving early anticoagulant, particularly in patients who had arterial thrombosis. But again, I said later, easier said to be done. When the surgery is planned for this patient, then we have to delay giving anticoagulant.
And anticoagulation. Pradeep, two important messages that you imbibe from this study, from the results of this.
Yeah. As devil's advocate, Anirban, honestly, I don't see any message in this because it's a observational study, very mismatched sort of two groups and guidelines. In fact, the authors do themselves mention there's already clear guidelines that anticoagulation has to be initiated when there's no surgical plan. So, which means the guidelines are already there. So, the early and late depends on the surgical intervention because this study very clearly says that surgical intervention saves lives because you can't have ischemic wall sitting there and you keep giving anticoagulation. So, so I think that's what would be my submission. There's no real take home for me, Anil.
Ajay, two important messages that emanate from this study.
Just, yeah, so actually, what I want to say is that going through this study, first of all, that we can simply stratify the protocol. When we are dealing with acute mesenteric thrombosis, first of all, whether the patient is having arterial versus venous thrombosis or NOMI. The patient of the NOMI are very sick. They need to manage for their underlying disorder. Arterial and venous, you can select this patient to start anticoagulation as per your surgical intervention, whether it's planned or not. If you think surgery is to be taken up front, then you delay. Otherwise, you can start an early anticoagulation. And I personally think that whatever patient we are seeing at our center with thrombosis, early anticoagulation does help, but we have very limited number of patients. So we are collecting the data
So that is, it is difficult to comment upon. That's
maybe
something
over
you.
time we have got
Ajit, your two important points that you think are can be carried from this study. I think we don't have Ajit anymore here, so I will finally come down to Kapil.
So this is
Ajit.
this study, this particular study, you know, in fact, it is to me, it just failed to scientifically prove that the early anticoagulation, early intervention, revasculation happened to. I mean, it is going to make a difference because obviously we don't know the severity of the disorder at the time of these interventions. So definitely it is impossible with this study. But anyway, in the human, when the patient is going to be critically, obviously early intervention is always better. So when it comes to anticoagulation, obviously, we do use an anticoagulation for arterial as well as venous thrombosis, but there was some literature previously, but it is there, probably, nowadays, we are using for both, but maybe the venous thrombosis might be a little bit better than arterial thrombosis, the anticoagulation. So maybe it is better to go for early anticoagulation as much as possible, because here we don't know whether the delay was because of the patient's condition. Second thing is the revasculation. Also, early revasculation is very important, because that not only shows that you prevent further propagation of the whatever the ischemic thing, especially the propagation of the ischemic bowel. Second thing is that there is a risk of an infection also going to be there. So more the ischemic bowel, more you keep like that, it is going to be ischemic. It is just going to have more chance of infections also. That is better to, so as much as possible, it's better to early anticoagulation, the early revasculation.
So that is your
as much
point
as possible will be the mantra to do.
Yeah. So Kapil, what are the two important messages that you want to
So
take from?
first important message would be know the devil, whether it's an arterial, venous, or NOMI. And then you have to do a risk assessment and decide whether you want to coagulate depending upon other factors. Second, most important is involve the surgeons as early as possible. You would lose the game. Even if you win the battle, you would otherwise you would lose the war. So involve the surgeons, and that's most important critical aspect here.
Yeah. So if the surgeons have any choice for surgery, they can do it early. Or if the surgeons don't have any choice and the intervention radiologist can do any to revascularize, probably that would be helpful. So that is the similarity in common between Ajay and Kapil, and I think the others also supported more or less the same way. And before I go, I will also ask Ashwin. Ashwin, what are the two new things that you have learned while preparing your slides for this study?
So the most important thing that I've learned while preparing for this is that for any study to be applicable in clinical practice, there has to be a certain level of evidence which has to be there. It has to be backed by a good quality of evidence. And this study perhaps failed to do so because obviously the number of patients that we see in our clinical practice who are suffering from acute mesenteric ischemia is number one, it is very less. Secondly, those patients that we have in our ICUs are not hemodynamically as stable, in whom we can use anticoagulation first before going for definitive management. So that is discrepancy. And I've also learned from this study, I've sort of, the take home message for me here is that if it is a NOMI case, we cannot go for anticoagulation. There has to be a definitive management. Anticoagulation can be taken up for consideration if it is an arterial or venous, depending if the patient is hemodynamically stable or not. If it is stable, we can try for anticoagulation. If the patient is unstable, any which way we have to go for definitive management only.
Yeah. Okay. Thank you, Ashwin. So, friends, there are a lot of issues concerning the use of anticoagulants in AMI, and although the study has tried to tried to, has revealed some of those factors. There are a lot of hidden factors, and some of those hidden factors have still escaped the notice of observational studies. So unless we have randomized control trials, unless we have matched controls against as comparators, and unless we do an exclusively follow-up of these patients, it is still difficult to say what is better. But as of now, it seems that full early anticoagulation works better for arterial thrombosis, and also the chances of revascularization and surgery, if can be performed early, will be good. So thank you for joining us. Keep joining us on the second and fourth Thursdays of the month for more such discussion on the recently published studies. Till then, from all of us in GICS Rapid Journal Review, Shubharatri, Shabar Khayat, good night. Thank you all the panelists.
Thank you, Anirban. Thank you, everyone.